so I'm gonna run through how to insert an NG tube and how to remove, which is your next check off here. I figured this would be a lot easier than watching the ATI videos, which don't do it exactly how your checkoff sheet kind of says. So I'm gonna do my best to follow along with your checkoff sheet. So if you see me reading this down here, it's just so that when I demonstrate to you, you understand exactly what your checkoff sheet says and exactly kind of what we expect for you to do, okay? So first things first, let's gather your supplies. So you're gonna need this. It's titled Salem Sump Dual Lumen Stomach Tube. And then you'll also need this irrigation tray and piston syringe, okay? In addition to these two things, you'll need some lube, which I'll give you here at campus. You don't have to worry about that when you're practicing necessarily at home. I'll give it to you here. And then you'll need your pen light, and you're gonna need some tape as well, okay? And you'll also need a stethoscope. I left mine at home, so I don't have mine, but you'll have to have your stethoscope with you for your checkoff as well to check placement. So first thing we're gonna do, per your checkoff sheet, assist the patient into a high Fowler's position, and then you're gonna assess the patency of the nares. So with that, you just take your pen light, look up in the nostrils, make sure it's clear and there's not a deviated septum or anything like that. And that's step two. You're gonna drape a linen saver pad or a towel or whatever onto your patient's chest just to catch any drainage or mess that may happen. And then if our patient, we're gonna let our patient know that we're gonna do an NG tube. Next, we're going to orchestrate some kind of signal for our patient. So we're gonna say, we're gonna be giving you an NG tube today. You're not gonna be able to talk very well while we're doing that. If there's something going on that you can't handle, please raise your hand and I will stop. Okay, so we're gonna arrange a signal of some kind. And then we're also gonna hand our patient a glass of water with a straw, and they're gonna need this at some point when we're inserting as well, okay? Then we're gonna prep our equipment. So we're gonna put on our clean gloves, and then we're gonna make sure that we measure the tube length correctly. Keep in mind that this procedure is not sterile, okay? So I've got my gloves on, just my regular clean gloves. I'm gonna open my tube. And this is kind of what you should see with an NG tube, okay? It's a long tube, it's coiled a little bit, and that's okay. We want it to be pliable so that it's flexible so we can get it where we need it to go, okay? The way that we're gonna measure an NG tube, so we need to know how deep we're gonna go. Well, it varies by patient. So we're gonna do what they call an NEX measurement. So we're gonna take the tip of this and we're gonna make sure we hold it taut, right? We're gonna take it to the tip of her nose, to her earlobe, and then hold it super tight there, and then from her earlobe all the way down to her xiphoid process, okay? NEX measurement. That right there is gonna tell you exactly how far you should go. You can mark it with a piece of tape, or you can mark it with a marker, or whatever you need to do, but you have to mark it somehow that way, okay? So you've got your tube measured. And then you want to make sure that you, now would be a great time to undo a piece of tape here to have it ready to anchor whenever we actually insert this, okay? And then now we're going to lubricate the tip of our NG tube here. So I'm going to open this lubricant. Remember, this is not sterile, so you could actually dip it right here. I'm just putting it on the plastic, on the paper that came inside my kit that this was all coiled into. And then I'm just gonna very aggressively and gonna lube it like that, okay? Your checkoff sheet says lubricate up to 10 centimeters. It's about where I've got there. So you just wanna not be stingy with the lubricant, okay? After that, we're gonna instruct our patient. They're sitting up straight in bed in high Fowler's. We're gonna have them tilt their head. You can't really tilt these mannequins very well, but in real life, you'd want your patient's head to look like this. Hyperextended to the back in that way, okay? And as that happens, we're gonna insert the tip of this down the floor of the nasal passage, and we're gonna aim it towards the near ear this way, okay? As we go through there, we're gonna continue that insertion until we're just past that nasopharynx. Typically your patient may gag or something to let you know that you're kind of close to that area. Okay, so we're gonna do that. We're gonna let them know we're getting ready to get started. Gonna insert that there. I don't have gloves on, so I'm trying not to touch all this crazy lubricant. There we go. Okay, so to the near ear, till we get past that nasopharynx, which we'll say is right about now, okay? And at this time, we're gonna have our patient flex her head like this, chin to the chest. She's gonna bring up her drink, her straw, and we're gonna instruct her that we want her to swallow every time we push, and we're gonna rotate the tube as we push in, okay? And we do that until we get to our marking, okay? So we're gonna say, and swallow, 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 until we're right about here, okay? And so then hopefully we give them a little bit of time to catch their breath at that point. And then they should be fine. So then at this point is when we kind of want to secure this tape. Your paper tape is not great for kind of butterflying outward, but I'm going to do my very best. And that's where you just kind of rip the tape in the middle and you make this little securement device. And you can kind of secure it here to their nose. Again, paper tape is not the best option for this, but we do our best. Secure it to the nose, and then you can also secure it to the cheek here as well. Okay, just kind of out of their way. You want to try not to cover the entire nostril. Again, this paper tape is not sticking, but you know, secure it here to the cheek, and then maybe even pin it to the gown or something to keep it there nice and secure. Now, your checkoff sheet here. It says here, ensure if your patient is gagging during the procedure. First things first, we're gonna make sure that we don't have a coiled tube in the back of the throat, okay? They're gonna be gagging because they're choking on that coiled tube. So we would just check and make sure, do we have a coiled tube back there? No, there's not one. If it is coiled, it says on here to take it out, let them time to rest, and then try again, okay? If it's not coiled, but they continue to cough or develop respiratory distress, we're gonna remove the tube and then give them time to rest before we reinsert. Now remember, throat anatomy, we're talking about airway and all of that stuff, so we wanna make sure that we're not accidentally getting this tube into the trachea. That's why it's so important to tell them to swallow as you're inserting so that that epiglottis covers that trachea and we don't accidentally go into the lung, right? So next with inserting is going to be verifying placement of the tube. Now there's a variety of different ways you can do this. It's going to depend where you work and your hospital policy as far as how you're going to do that. So we've listed all of the ways that you can do it, so you'll just need to know all of these different kinds. So first of all, inspect the posterior pharynx with the pin light for presence of coiled tube. We just did that, but that's one way to kind of look at that, okay? Second, it says aspirate stomach contents and measure pH level. So that's where this piston tip syringe comes in. I'm gonna open this. And this is what you should have in here, okay? This is like what you could put some fluid or liquid in, and then this is your syringe here. So if you're aspirating contents here, you'll notice here at the end of the tube that you have this blue pigtail here. Nothing ever goes in this pigtail, it's just a vent, okay? So you never hook that up to suction, you never do anything with that. This is the end kind of that we're working with. And it has this little adapter here, and that's so that it will connect to suction. So keep that handy, but you're gonna need to take it out while you're aspirating your stomach contents. So when aspirating stomach contents, you're just gonna put this into this hole here. You're gonna pull back, and you're gonna see stomach contents hopefully come all the way up through this tube and into your syringe. And then a lot of times they'll have like a pH piece of paper, and you would just take this out, put it on the pH paper, see if it turns the right color or reads the right number, and then that would be a way to verify that, okay? Also, you can actually put this back in at this point for now. You might need to actually take it out here in just a second to do another type of verification. Oh, and then it says, ask the patient to speak. So you ask them if they can talk. Obviously, if there's a coiled tube in the back of their throat, they're not going to be able to speak very well. And then lastly, another way that you can check placement is to auscultate and to see if you can hear a whooshing sound with your stethoscope. So when you're doing that, it says on here, let me find where I was at, inject air into the NG tube and auscultate, listening for a whoosh of air. I wouldn't inject any more than about 10, okay? So I'd pull it up to here, because remember, you're putting air in their belly, which is gonna cause them to have gas pain and things like that. So the least amount, the better. So pull it up to about 10, so you have air in your syringe. You're gonna insert your syringe right here, and then at the same time, you're gonna put your stethoscope on, take that diaphragm of the stethoscope, and put it right over their belly right here. And you're gonna listen while you push this air in. And what you should hear is kind of a sound that sounds like it sounds like air moving through like a hollow cavity, and that's kind of what you're looking for. And that's going to confirm placement in the stomach. It's important for you to note as well, and it doesn't say this on your checkoff sheet. However, it is important to know that a lot of times in different facilities, sometimes they may require a chest x-ray first to confirm placement before you insert anything into an NG tube or a G tube or anything like that. So it's important to be aware of that and just look at your hospital policy. But for this particular checkoff, this is really all you need to know as far as how to check placement. And then your next steps, it says tape the NG to the side of the cheek and the gown. We already did that. Connect to feeding or suction per MD order. Okay, so I've got my suction tubing, which we know is connected to the suction canister that we went over, and we'll just connect it here using this little adapter, like so. And now fully connected. If they were ordered to have suction, we would turn on the suction, the wall suction right now as well. And we want to make sure that we maintain the head of the bed at least 30 degrees for this, because any patient with any kind of tube feeding, if they're constantly getting feeding or things like that, they're at the risk for aspiration. So if you're laying flat, you're at a higher risk for aspiration. So we always want to keep the head of the bed elevated to at least 30 degrees with these patients. Then you're going to do your final steps. And then you're going to go document. It says to document the nostril used for insertion, measurement of the exposed tube in centimeters to determine correct placement. So we would say how much is left on here. We could just say that you anchored it to, I think I anchored it to 47 centimeters. You can just document that. That would be fine. And then the characteristic of the drainage, if it's draining, what does it look like? How does it smell? And then lastly, the patient's response to the procedure. Did they tolerate it well? Okay, and so that's really it with insertion. It's a little easy because it's not sterile, so that's like one of the biggest things that is hard for you guys, is maintaining that sterile field. You don't have to do that in this checkoff. And so then we go right into removing. You don't have to do your initial steps again because you've already done it. So first thing we're going to do, prepping for the procedure. Your checkoff sheet says ensure that there's a provider's order to remove the NG tube. So we're going to make sure that is. We're going to make sure our patient's in high Fowler's position. We're going to give our patient a tissue or a linen saver pad here on the chest, or we can give her a tissue and tell her to hold it because her eyes are probably going to water. She may feel like she has to sneeze. So we're going to do that. We're going to explain the procedure, explain to them it may cause some gagging and discomfort. And then we're going to put on our clean gloves, okay? When we're removing the tube, first thing you want to do is disconnect it from suction here. Get rid of that. You want to kind of hold it like this so we make sure that the drainage goes into the suction canister, because if we lay it here to gravity, it's going to spill all over the bed. Same with this tube. Make sure that you're kind of holding it upright because it's going to spill stuff all over the bed. And then it says on your checkoff sheet that you want to make sure that you're going to flush 10 milliliters of air into this, because we're assuming this is all full of drainage at this point because she's been draining for a while. So we're going to pull it up to 10. We're going to put it in here, and we're going to put that air in, which is hopefully going to flush this tube out, put all of her stomach contents back in her stomach, and give us a clean tube so when we pull it out, it's not a huge mess. Okay? Then we're going to clamp or pinch the end of the tube to prevent it from draining out, right? So we're going to keep that pinched while we pull it out. And then lastly, it says grab a piece of gauze, which if I can use this is fine. We'll grab a piece of gauze. We can hold it up to the patient's nose, tell them to hold their breath. Please hold your breath. I'm going to pull this out and just literally pull it out like this. Got your clean gloves on. You can wrap it in your glove and throw it away. Okay, do your final steps, document, and then you're done.